Good morning, students. In continuation, we are going to see the ventilation and perfusion at different zones of lungs. Up till now, we have discussed in detail the ventilation, how it occurs, what are the physical factors, what is the functional anatomy, everything related to ventilation we have seen. And in the last session, what we have seen is perfusion, that is pulmonary circulation, the peculiarities of the pulmonary circulation and how it is important functions are done by this pulmonary circulation. So with this particular knowledge of perfusion and ventilation, what we are going to see in this particular session is ventilation and perfusion at the different zones of lungs. Now this ventilation and perfusion is why it is important to have is there is a particular term which is very commonly used to examine, and that is ventilation perfusion ratio. So why? Because there are regions in the lung where ventilation and blood flow are not properly matched. So we have ventilation across the lung, we have the blood flow across the lungs, but there are some regions where they are not matched. And due to this physiological mismatching, a small fraction of cardiac output, that is blood flow or perfusion, is not normally fully oxygenated because it is not getting the ventilation. The matching of airflow to blood flow is studied by examining this ventilation perfusion ratio. So physiologically, there are some regions where there is mismatching. And as a doctor, you should know what are these areas, how they are going to affect the ventilation. If this is affected, the gas exchange is affected, and we should know these regions or zones. So the normal value of this ventilation perfusion ratio, which is we are going to study, is 0.8. So this ventilation perfusion ratio on an average is 0.8. Now what exactly this VP or VQ ratio is? It is the ratio of alveolar ventilation and the amount of blood that perfuse the alveoli. So very simple, it is the ratio of ventilation to perfusion. So it is in some books it is denoted as VP ratio, and in some books it is denoted as VQ ratio. So how do we calculate this? Ventilation divided by pulmonary blood flow. Now ventilation, we know that alveolar ventilation is 4.2 liters, whereas the pulmonary blood flow is around 5 liters per minute. So if we put these values in the calculation or the formula, we get the PQ normal ratio as 0.84. Now how these zones are divided? There are three zones where, according to the perfusion, the lungs is divided into three parts: zone 1, zone 2, and zone 3. So this particular part is apex, this is the middle region, and this is the base of the lungs. So if you see by this particular figure, if we are going to see this particular figure, there are zone 1, 2, and 3. Zone 1 where the perfusion is absent, zone 2 where the perfusion is sporadic, very less, and zone 3 where the constant perfusion is present. So these are the zones which are by perfusion. So blood flow will be like this. Zone 1, no blood flow. Why? Because there is a negative intrapleural pressure, more negative intrapleural pressure, and due to this more negative intrapleural pressure, the size of alveoli is much more, and there is arterial pressure also less due to the effect of gravity. That decreases the diameter of the vessels at the apical region, and due to this, the zone 1, which is the apical zone, has actually no blood flow. Then comes the middle part, which is zone 2, where sporadic or intermittent blood flow is present. Here, the arterial pressure is greater than the alveolar and the venous pressure, whereas the pressure in the venous, the small veins, is less than the alveolar pressure. So that is, due to this less pressure in the small venules, the venules will be collapsed. and as the venules are collapsed, the gradient, which is arterial venous pressure gradient, will be intermittently maintained, and due to that, the intermittent constant blood flow is always there in the middle zone. Then comes the lowest part, which is at the bottom of the lungs, which is zone 3, having continuous blood flow. Due to the effect of gravity, there is a high pressure, and high pressure creates vasodilatation, and that is the cause of more blood flow in the basal zones of lungs. So the perfusion zones will be zone 1, no blood flow, zone 2, intermittent blood flow, and zone 3, continuous blood flow. And the cause of these zones is we have discussed. So this is how it is there, ventilation and perfusion. So we can see here in this particular figure, there is apical zone, there is middle zone, and there is basal zone, where the perfusion is given. Here it is 0.56 milliliters per minute, very less. Then here it is continuous, intermittent, 5 ml per minute. And at the basal region, it is around 10.3 milliliters per minute, which is much more. So this is the position or the values which are of perfusion. So we have seen the zones of perfusion. Now we are going to see the zones of ventilation. So zone 1 is having the ventilation around 1.92 liters per minute, and this is at the apex level. So the reason why, because there is increased size of alveoli at the apical region. Then zone 2, which is of 4 liters per minute, here there is intermittent size of alveoli, whereas zone 3, which is at the base of the lung, the zone is having less size of alveoli, and so the ventilation will be more, 6.5 liters per minute. So from the apex to the base, the ventilation also increases. From apex to the base, the perfusion also increases. We have seen these, we have already discussed all these 2 points in previous sessions also, but here just VQ ratio we are discussing, and in that again I am repeating these same things. So these will be the zones and of ventilation. So in perfusion also and in ventilation also, due to the effect of gravity, you have increase in the ventilation, increase in the perfusion from apex to the base. So this is what is there. So base, it will be much more, both the perfusion and ventilation, and apex, it will be less. And if you are going to find out the ratio of these two, then it will be different at base, it will be different at apex. If you measure this, it will be at the apex, it will be, see, this is, if you consider only zone 1, where ventilation is much more than the perfusion. So both are like less, okay, but ventilation is somewhat more than the perfusion. So the VQ ratio is 3.4, which is high. Zone 2, if you are going to consider, here the ventilation and perfusion almost are equal. So the VQ ratio is average around 0.8. And whereas the zone 3, which is the basal part of the lungs, the perfusion is somewhat more than the ventilation, as we have seen in the previous slide. So the VQ ratio is coming to lower side, and that is around 0.63. So these are the values which you have to remember. Actually, instead of values, you can remember what process is there. The ventilation, where it is less, where it is normal, where it is more. The perfusion, and what is the comparison, where it is, see, if you consider the zones here, we can see in the apical region, ventilation is more as compared to perfusion, whereas in the zone 3, which is basal region, perfusion is more than the ventilation. Now these again are very important point which you have to remember, as they will cause different types of disorders if they are changed. Now in upright posture, the base of the lung is better ventilated and better perfused than the apex. So after knowing these values, we can say that the base is better ventilated, better perfused. Moreover, the blood flow, as we have seen, the perfusion is greater than the ventilation at the base, whereas the ventilation is greater than the blood flow at the apex. The blood flow exhibits about five-fold difference between the apex and the base, whereas ventilation only two-fold difference. This variation in the differences in the ventilation and perfusion is resulting in the regional differences of VAQ ratio. And this VAQ ratio is 0.6 at the base, which is low, about 3.6 at the apex of the lungs. What is the importance? Why you want to know the VQ ratio? The physiological importance is that it is important for the gas exchange in the lungs. Of course, both of these processes are important for gas exchange. At the apex, the VAQ ratio which we have seen is high because there is more ventilation related to the blood flow. Therefore, the alveolar oxygen tension is high and carbon dioxide tension is low at the apex of the lungs. At the base, the ratio is low as there is more perfusion than the ventilation. So some amount of the blood circulates through the base of the lungs without becoming fully oxygenated. So these important points. So if you are having a scan or an X-ray, we can see that the aeration will be much less at the base. And this physiological differences we have to remember. The clinical importance. Due to the difference in these regional VAQ ratios, some diseases are more localized to the part of the lungs. For example, the most common disease which is found in India, tuberculosis, it occurs more commonly in the apex because the tuberculosis is due to Mycobacterium tuberculosis infection, and these bacteria, they have the favorable environment which is higher oxygen level. Because there is more ventilation, it gives an higher oxygen level, and this higher oxygen level at the level of apex facilitates the growth of tubercular bacilli. So if you see the X-ray of the tuberculosis patients, you can see that infection is more common at the apical region. The effects of changing this ratio, if the ratio is decreased, when ventilation to an alveoli is reduced relative to the perfusion, the VAQ ratio becomes less. Okay, so whenever the ventilation is less as compared to the perfusion, the ratio will be less. In this situation, due to delivery of less oxygen, the alveolar PO2 falls, and due to removal of less carbon dioxide, PCO2 rises. So these are the changes which are seen whenever the VAQ ratio is decreased. The effects, what we are going to see, that already we are discussing. So we have discussed decreased VAQ ratio. Now here increased VAQ ratio. When the perfusion is reduced relative to the ventilation, the ratio increases. Now here the alveolar PCO2 will be falling due to less carbon dioxide delivered into the alveoli from the blood, and PO2 will be increased as less oxygen is transferred from alveoli into the blood. So these will be the changes whenever there is increase in the VAQ ratio. Now, when these values are very much important, whenever a serious patient comes to you, you have to do the pulmonary or arterial blood gas analysis, and depending on these gas analysis, we have to correct that particular condition. So in the lung function test also, a part of lung function I have given that the blood gas analysis is done. So if you visit to the ICUs, we can see MICUs, ICUs, NICUs. We see that every patient will be having the analysis of blood gases. And here, this is an important part which is going to change this blood gas. So these will be the changes which are often seen. So this is decreased ratio. So suppose there is a bronchial obstruction and this is an alveolus, this is an artery, pulmonary capillary, so which is having this alveolation. Now this is, if there is a obstruction, it will decrease definitely the ventilation. And if it is decreasing the ventilation, but the perfusion is normal, then it will create increase in PCO2 because it is not able to give out the carbon dioxide. So the amount of carbon dioxide will be much more and the alveolar PO2 will be decreased because the perfusion is normal. So this will be continuously going on. So carriage of oxygen is normal and due to that PO2 will be decreasing but the PCO2 will be increased if the decreased VAQ ratio is there. Now, if there is increased VAQ ratio, now here you can see the ventilation is normal, but there is an abnormality in the capillaries. So here it is a perfusion. So if there is a obstruction in the vessel, so the perfusion is abnormal. Now what happens in this particular case? The perfusion is reduced and that gives an increased VAQ ratio. So the alveolar PCO2 will be decreased. So because the alveolar ventilation will be normal and due to that the CO2 will be given out and due to that the PCO2 in the alveoli will go on decreasing but the alveolar PO2 will be increased. Because the perfusion as it is abnormal, the capillaries will not be able to take up the oxygen. So the oxygen will be remained here inside and that will increase the partial pressure of oxygen. That also creates the venous admixture and the physiological shunts. So whenever the changes are going to occur, there will be admixture. Admixture is in simple language the pure and impure blood. So the oxygenated blood and it is not oxygenated blood, deoxygenated or which is not able to reach that alveoli. So there will be venous admixture. So the blood which is coming out from the heart will be having some amount of venous blood. So that is not an oxygenated blood. And there might be creation of physiological shunts. So what is that? Like physiological dead space that causes the wasted ventilation, there is wasted perfusion also. This wasted perfusion refers to the quantity of venous blood which is not fully oxygenated. So there is a blood which is not fully oxygenated and the mixing of this unoxygenated blood with oxygenated blood is known as venous admixture. And this venous admixture occurs either due to a shunt or to a low ventilation perfusion ratio. And this perfusion is known as wasted perfusion. Now, what are these shunts? A shunt is a channel in which the blood bypasses the lungs. So it is not reaching to the lungs, it is bypassing the lungs. And if it is bypassing, that means it is not completely oxygenated. There are two types of shunts. Anatomical shunts. In this, the blood bypasses lungs through an anatomical defect. So if there is a genetic anatomical defect, for example, right to left shunt, admixture of blood occurs through the atrial or ventricular septal defect. You must have discussed already in the cardiovascular sessions that if there is a septal defect, septum is which is the part which separates the atria from the ventricle. And if by birth a genetic abnormality is there and there is a defect and which is creating a channel and that creates a right to left shunt. This also occurs due to a branch of pulmonary artery connecting directly to the pulmonary vein. So if these anatomical defects are there, then it will cause the branch of pulmonary artery and the anatomical shunt also. There can be a physiological shunt. Here in bronchial circulation, deoxygenated bronchial venous blood will be draining directly into the oxygenated blood of pulmonary veins. So in the bronchial venous circulation, the blood which is there is deoxygenated, but it will be directly draining into the oxygenated blood. And this accounts for physiological shunt. Normally there is a physiological dead space as well as the physiological shunts in the lungs. And you have to be very careful regarding these values. Now, the low ventilation perfusion ratio occurs when a fraction of pulmonary capillary blood is not oxygenated due to low alveolar ventilation. Normally, this occurs at the base as we have already discussed, and this can also occur if an airway is partially obstructed, causing the hypoventilation. The fraction of the blood that passes through a hypoventilated part of lung is not fully oxygenated, and this results in venous admixture. Thus, this anatomical shunt can cause the hypoxia. So, in normal healthy individuals, the maximum venous admixture is about 2% of cardiac output. However, in some bronchial disorders, this amount can increase up to 20% of cardiac output. And in congenital disorders with right to left shunt, it can increase up to 50% of cardiac output. And in these conditions, the gas exchange is grossly impaired. Clinically also, some signs will be seen as, you can see the bluish discoloration, and immediately we have to treat this condition. Many times you must have heard that the blue baby are seen. Why? Because these by birth they are having some shunts, and due to that there is a deoxygenated blood which is color can be not red, blue. So that is why they are termed as this. Now there is a special mention regarding this pulmonary tuberculosis also. Most of the time the apical zones of the lungs are affected by pulmonary tuberculosis because there is a low perfusion, there is high VQ ratio due to high PO2 and low PCO2. So they, as these tubercle bacilli are aerobes, they will grow more. And less of the oxygen is carried away by the blood in the apex. So highest oxygen is available that produces the pulmonary, differentiates the tubercle bacilli, and that will cause the pulmonary tuberculosis. So in summary, zone 1 is having 3.4 VQ ratio, zone 2 is average 0.8, and zone 3 is low 0.63. The zone 1 at the apex, ventilation is more as compared to perfusion. Zone 2 in the middle part of the lungs, ventilation perfusion almost equal. Zone 3 at the base of the lungs, the perfusion is more as compared to ventilation. So apex again is more infected by pulmonary tuberculosis. So I think that is all related to ventilation perfusion ratio. This is a very common question which is asked in the examination. What is ventilation perfusion ratio? What are the different zones, how it is created, and what is the normal value? So that is a very common question. So just go again through the books and go again through the video sessions. Thank you.